Hello, everyone, and welcome. My name is Sam Bass. I'm with the Market Intelligence team here at Open Minds. And today, as part of our weekly private roundtable series, we have Open Minds Senior Associate Joe Naughton-Travers, who will be discussing launching blended service lines for a post-pandemic market. Joe has more than 30 years of experience in health and human service field. During his tenure as a senior associate with Open Minds since 1998, he has served a lead of dozens of client initiatives, served as editor of Open Minds publications, and is author of many groundbreaking articles and presentations. Now, before we get started, I have a couple of brief housekeeping reminders. First, while you are muted during today's briefing, we are open to any questions that you might have. Please feel free to submit those in the question box that should be on the right-hand side of your screen, and Joe will have time at the end to answer those. And secondly, as a reminder, the recording and PowerPoint from today's briefing will be available tomorrow on the Open Minds website. And without further ado, I give you Joe.
Hey, Sam, thanks so much, and thanks to our audience. Sam, we have to remember to update my bio. It's been now 40 years of experience because I'm much older now at age 60. So
I'll make a note. Sorry about that. 40 years.
it's kind
Let it
to
be known.
make me a bit younger, but I'm certain our audience, many of them have met me before, and I'm really excited about our presentation today. So I'm going to pull up my slides. Sam, you keep track in the background of questions, and you can pop on after I do the presentation, and we'll chat with folks, okay?
Absolutely. Sounds good. I'll see you then.
All right. All right, Sam, I'm just confirming everyone can see my presentation.
I can't see your screen.
Isn't that amusing? Because it worked perfectly just a moment ago. Let's do this. Now?
Now I can't see you or the screen. Let's see.
That's let me, I really am doing screen share here, so.
There we go. Now we can see your, oh, no, it just went away.
Can you see it now?
Yes.
And can you see it now?
Yes, but we cannot see you.
Oh, that's okay. I don't look so great today, so I'm not sure. Oh, let me try this. Can you see me too?
Perfect. There we go.
All right, that's weird. Now I can see myself too. It's a little strange. So audience members, you've all been Zooming or attending virtual meetings. So every time we do these sort of virtual presentations, even though we practice, we run into snags. So thanks for your patience for a couple of minutes there. What I really want to talk about here is how we plan blended services going forward as an organization. So, you know, what's happened during the pandemic is that last March and certainly early April, all of us needed to quickly lock down and figure out how to deliver services to the consumers that we serve. Some programs were shut down entirely. Some programs needed to switch to virtual overnight or within a few days. So we really did have an emergency response to the pandemic to make sure that we were serving our consumers as well as keeping our staff safe. So what's fun for me about this presentation, and this is really a new one, is really thinking beyond pandemic about what we should be planning for how we deliver services. So my outline for this is really, you know, the overall landscape, which is the thing I just started to talk about. But number two is the part I really want to focus on, which is what are the key steps in launching virtual and hybrid services. Number three is really just a slide, but I want to tell you, and I have a whole presentation about this, that whether we're developing a new service or modifying a service, there really is a best business practice about how to do that. And then number four is really, I have a modified case study of an organization I worked with about how they planned and implemented virtual and hybrid services. I'm leaving plenty of time for questions or comments at the end of at the end of my presentation. So again, if you have any questions or comments, put them in the question box. My colleague Sam will keep track of them. And then when I finish the presentation, I'll come back on camera and put down my PowerPoint, and we can really talk about these things.
Hey, Joe, this is Corey, GM in the background. Your slides are not advancing.
I'm on the agenda slide. Can you see it?
No, we're still looking at the title slide.
Corey, this is what happened to us last time. So I have to, all right. We had this problem before, and I mentioned this to you, Sam, where I might need to switch to apologies, audience. This is a snag we've run into before. Where do I get to pick the screen? Sam, I don't have the option to pick what I'm displaying anymore. Because before what I've had to do is display my whole desktop. Can one of you pull up my presentation and maybe let you guys present it and I'll lead you through it, if that will work?
Sure, I'll pull it up.
Yeah, so let me stop sharing. Corey, this is exactly what we had happen last time and I can't figure it out. Audience members, I do apologize. It's the amusements of technology. All right. So is that you, Sam, that's pulled that up?
Yep, can you see this?
Yep, I can see it. Why don't you go to play mode and I will just tell you when to advance the slides. Thanks so much.
Now,
It's showing presenter mode.
oh my goodness. Okay. What if I do this? I'm sorry, it's also not letting me decide which screen to show.
Yeah, so we can live with it in presenter mode. It's not perfect, but I don't want our audience to wait. So why don't we go ahead and do that? And then perhaps after this, we'll figure out what the heck is happening. So for our audience, the display isn't exactly what I would want because you're actually getting a preview of the next slide. Can you move that? Can you squish the line over there, or is it stuck? Yeah, that works. All right, so to our audience, let's talk about planning for your hybrid future. You know, as we move through this pandemic, and we're not post-pandemic anymore, as you know, but we're trying to figure out what the next normal is like in healthcare in terms of how we deliver services and what our customers and payers expect. So we've all been doing many things virtually, except when we when we couldn't, when we had to see people face to face. But what we're beginning to understand now is that health plans and consumers expect some blended model as we go forward. You know, it's nice to be able to see your therapist on telehealth rather than drive to the office. It's nice to be able to communicate that way. And of course, there'll be times when people need to be seen face to face, or we need to do home visits, or, we're running a group home or other sorts of things. But we believe at Open Minds that part of the strategy going forward is to move beyond the sort of crisis management model of delivering virtual care to planning for a hybrid future that actually will better serve consumers, actually may make it less expensive for you to deliver services, and it's really what payers expect. So next slide. It's interesting to see how quickly the healthcare world moved to telehealth. Before the pandemic, there were folks doing telehealth. There was a lot of telepsychiatry and other sorts of things in the marketplace, but less than 1% of visits were telehealth. But when the pandemic hit in March and April, everything switched. very rapidly. Some people struggled with it. They didn't have the infrastructure. Other providers were actually ready and were able to flip overnight. So in the first quarter of the pandemic, 80% of behavioral health services and 70% of primary care visits became virtual. So we were all on Zoom essentially at that point in time. But now we're really pivoting to what it should look like when we get beyond the pandemic, and how should our services look, and who should we see face to face, who benefits from virtual, and what's the hybrid model that works for folks. And so the key thing I want to get across to you today are the steps for thinking about that strategically, rather than just responding to the crisis that we all had to 16 months ago. Next slide. So I do like to talk about my definitions of services. So there's two slides here. The first is face-to-face services. This is what we've all been doing for decades. It's how we delivered services. You would go in to see your therapist, or your therapist would come to your home, or your case manager. It's really the broad notion of how we delivered services, and it's also driven by traditional billing requirements. So you may have day services that are billed on a daily basis. You have outpatient therapy that is billed in 50-minute increments or other sorts of things. The service delivery was in person, either in offices, homes, or the community, but it was also, the services were defined by how it was billed. Virtual services are doing things via telehealth or telephonically. It's the thing we've all needed to do over the last year. Everyone switched to video and audio. In some jurisdictions where folks didn't have access to video, they were actually delivering services just over the phone. So the broad notion of virtual is you're not in the same room. And we certainly know during the pandemic, the payers have continued to pay for services and quickly allowed us to be paid for services, delivering them virtually. But if we move on to the next slide, I really like to think about hybrid, which is, let's assume we get the pandemic under control and we're really deciding how to best serve the people we serve. And so hybrid is really a combination of that face-to-face and virtual services. So perhaps my initial diagnostic psychiatric assessment is face-to-face, and then we deliver services virtually. Or perhaps even my assessments are virtual, but I need injections or I need other sorts of things, so I obviously have to have some face-to-face. And then there are some consumers and settings where we're always going to be face-to-face. If we run a group home where people live there, our staff have to be there. But the broad notion of hybrid is thinking about the blended model of face-to-face services and virtual services. Now, what I'd really like to highlight on my slide here is the notion of add-ons, because when we're starting to brainstorm about moving forward and redesigning our service delivery so it's great for consumers and payers and for us, I like to think of add-ons too, because we usually just think of face-to-face versus telehealth. But if payment models allow us, we can think of hybrid models of including a number of things. So for instance, less rigid service definitions. Does outpatient mental health therapy always have to be 50 minutes? Or can we do 10 minutes, or ad hoc? Can we use texting, email, the portal, and other sorts of things as a way to communicate with the consumers we serve or provide services? Can we use remote monitoring? Suppose I'm a consumer with a severe mental illness who's in supported housing or independent living housing. So I have an apartment. If you use remote monitoring, you don't have to have a case manager visit me all the time. You can have a camera and audio so you can check in on me and not have to be there physically. And then there's the notion of asynchronous care. Can I send an email or text to my therapist or a video and get a response and look at it later so that it's not live? And then also where do phone apps fit in this? There are ways to report symptoms, to communicate, and all sorts of things. So I call these the add-ons that I really want us to think about in terms of hybrid care, because they really allow us to use technology to better serve people in all sorts of ways. And then my last bullet point here is that I describe the add-ons for only hybrid, but the reality is some of them may benefit those consumers that need to be seen face-to-face only. So maybe you have a consumer that really has to be seen face-to-face with her psychiatrist, with her therapist because of whatever challenges she has, but maybe a phone app also helps her communicate with her care team and other sorts of things. So I've described them as add-ons to hybrid, but I do want us to think about going forward that these could also be used for the consumers that need to be seen face-to-face. Now, part of the challenge here is that we have to figure out how we're being paid in order to look at these add-ons in particular. So let's move on to the next slide and talk about the key challenges that folks have when they're thinking about virtual and hybrid services. So identifying the consumer subpopulations, sort of organizing them and thinking about it, and that'll be part of the steps I talk about here. And then there's new operational models for how we deliver services. If we're going to be doing mostly virtual or some hybrid services, we really have to look at how we run our organization, what offices we need, where our staff are, all those sorts of things. The third one is obviously critically important, which is we have to make sure we're being paid for services. So if we do hybrid services, will we continue to be paid for them? It's our belief at Open Minds that all the payers will continue to pay for virtual telehealth kinds of services. We'll wait and see, but that's our belief because it's worked well in this difficult time. But then if we think about the add-ons, if we're starting to deliver 10 minutes of psychotherapy instead of 50, then it starts to move away from traditional billing models of how we track services. So in those cases, we're probably looking for some alternative payment arrangement with our payers that would allow us to be more flexible in how we deliver services. The other things are sort of obvious. We have to train our workforce. We have to make sure that people actually have access to the technology. I have a wonderful customer in Kentucky I've been working with for years, and part of their challenge when they went virtual is not everyone had laptops or internet access or any of those sorts of things. So there really is a pretty serious digital divide in the States in terms of who has access to high-speed internet, the technology so that they can use virtual or hybrid care. And my last point on this slide is when we start to switch to virtual or hybrid care, we need to be thinking about the fact that there's broader competition. My customer in Kentucky, for instance, delivers wonderful outpatient mental health services along with a whole other array of services. But if someone in California wants to start offering virtual care and they can get the right licensing, they could actually compete in the Kentucky market. So it's an opportunity, but also, once we move to virtual, my colleague Sam lives in Texas. I live here in North Carolina, and my other colleague Corey lives in Pennsylvania. We don't have to be in the same place, and it's the same thing for our staff. People can be in different places, so it's an opportunity, but also a threat from a competition standpoint. But Sam, let's move on to the steps. I want to talk about, you can move on to the next slide. This is the summary slide for my audience members. There are 6 key steps to thinking about launching virtual and hybrid services, and I'm going to talk about more of each of these more in the coming slides. The first is to identify consumer and server groups service groups for analysis. The second is to really brainstorm the best model of care for each of those groups. And some of the rest of this is really just logistics, access to care, making sure we're getting paid, training our staff, and revisiting our operations to really support this new model of hybrid/virtual care. So Sam, let's go on to some of the detail, but let's talk about the first step. So the first thing you do is look at who you serve and what services you deliver to them and group them. So outpatient mental health services, my typical example. If you deliver outpatient mental health services, you've already switched everything to virtual, essentially in the last year. But let's think about that group again. Those individuals, severe mental illness, substance use disorders, and they're being treated in an ambulatory outpatient setting, but now virtually. So what else could we do for them? Or what should we do differently? Are there certain consumers that actually have to be face-to-face because of the challenges they face? How do we blend the fact that some things need to be face-to-face, like injections, and sometimes psychological assessments or other sorts of things? So the notion here is think about the people you serve and group them so you can begin brainstorming how you would develop a hybrid model or enhance the virtual model you already have. My other two examples here are IDD, Intellectual and Developmental Disability Group Homes. For those folks, they certainly have had to provide services face-to-face, because we're staff in a group home and we have to be there. And so even during the pandemic, that was always face-to-face, but there still may be an opportunity to look at hybrid and add-on things. Can we do consults for folks virtually? So we have staff in the group home, but we're getting a psychiatric consult or other sorts of things, and that doesn't need to be face-to-face. Are there ways we can use the communication technologies to allow them to better communicate with their families in other parts of their care team? My third example is about supported housing and independent living. Again, this is the notion I might be someone with serious mental illness who you're helping live independently, and typically you've had a case manager come and visit me. But can we use remote monitoring? Can we use phone apps and other sorts of things? Can some of the visits be virtual and combined with a periodic face visit? So the whole goal here is to sort of think about your services and consumers in cohorts so you can begin brainstorming about how to move forward. So let's move to the second step. Here is where you really think about the hybrid care that you could do for each group. There will be some consumers that always need to be seen face to face. Maybe you do work with kids with that are more challenged on the IDD side, who have a more serious autism spectrum disorders or behavioral disorders that don't respond well to virtual care, or it's not as effective. So as we think about moving to hybrid models, we need to be thinking about the individual consumers, and there'll be some folks that really need the face-to-face care to get the quality of care that we're looking for. And then, as I spoke about with the last slide, it's beginning to figure out what's the combination of face-to-face and virtual. And your clinical team may have some opinions about that too that I think would be important. So for instance, if I'm a psychiatrist, it's possible that some of us as psychiatrists would want to say, you know what, when possible, I really want that first psychiatric assessment to be in person so I can really completely see the whole person, do an assessment, and then I'm comfortable with doing med visits and follow-up later. Again, I'm not telling you that's what you should do, but that's part of looking at your clinical models and determining, are there some things that we absolutely want face-to-face? When we're doing psych testing, for instance, that is normally all done face-to-face. So it's about thinking about the combination of face-to-face and virtual models for each of those consumer cohorts we talked about. And then I really like to move on to talking about the add-ons. So let's move on to the next slide and talk about the add-ons. Oh, sorry. One thing before that is the, you can stay there, is the consumer access design issues is, traditionally, our services have been designed for the staff members and not for the consumer. Again, going to an outpatient example, most outpatient mental health clinics operate, on weekdays from 9 till early evening or something like that. As a consumer, I might want to be seen on a Saturday or Sunday or in the early morning or other sorts of things. So part of repositioning ourselves and redesigning our service lines is thinking about, are we doing this for the convenience of staff or what do consumers really want? And my colleague Monica always talks about, now that we're moving through the pandemic, we always need to think about digital first. is there a way technology could handle this? Can we get a first visit by going to the website and calling a 24/7 call center, scheduling, billing payment, all those sorts of things, and using technology whenever possible, rather than assuming that if I'm going to outpatient therapy again for the first time, I have to go into an office, fill out paperwork, meet with people, show them a copy of my Blue Cross card. Where can we really accelerate the use of technology? So Sam, let's go on to the slide I really wanted to talk about, which is the add-ons. So the broad notion here, if you remember from my earlier part, is that when we're thinking about changing how we deliver care, and particularly from a hybrid and virtual model, we like to think about doing things differently too. So again, different service definitions. Can we do 15-minute psychotherapy sessions instead of 50? Can they be on demand? Can we use those other technologies like texting, email, the portal, remote monitoring, asynchronous care, phone apps and other sorts of things? The middle part of this slide is really the most important part. When you're thinking about these add-ons, and again, you can use these for face-to-face folks as well as virtual, as well as hybrid, but I'm really talking about them for the hybrid model primarily. You have to evaluate the benefit in a number of ways. So these questions are really important. Do they make it more convenient for consumers and their families? If I can get into care quickly, I don't have to drive somewhere for an appointment. If I can do telehealth, that's really convenient. I know even for myself and my family, most of our medical visits have been via telehealth. We don't have to drive anywhere to see folks. Do they improve communication between consumers and their care providers, as well as amongst care providers? So this is the notion of, the portals and texting and email and all those sorts of things. Does it actually allow us to communicate better and actually deliver better care? Do they improve the efficiency or reduce cost of care? Do they improve the quality of service and consumer outcomes? Do they help ensure consumer safety? So in particular, I was thinking of the remote monitoring things here. If I'm in that independent living facility and you have a video camera and audio, you can check up on me and make sure I'm okay. And then lastly, do they increase brand preference? I was talking to a colleague today about a presentation I'm doing next week, and she was talking about her kids who needed some, medical care. And she's like, I'm only working with doctors now that have a portal and a website where I can set up an appointment and do telehealth as a starting point. She said, I'm just not working with other healthcare facilities because it needs to be easy. And I really prefer folks that have this technology in place. So let's move on to the next step. Revisit your access to care. So again, if we go back, we have patient cohorts, consumer cohorts, where we're dividing them up. We're brainstorming about what's the best models of virtual and hybrid care and whether or not add-ons are possible. And then we move on to the basic notion of access to care. Again, I want to be able to go to a website, search for a substance use provider near me, quickly find the best one, click on a link, and either be able to ask for an appointment or have access to 24/7 call center or other sorts of things, or even access to on-demand services. So as we shift to hybrid models, we really need to revisit our whole front end in terms of how people access care or how referrals come in. So if we move on to the next step, this is really thinking about making sure we're going to get paid. So again, during the pandemic, payers are paying for traditional services that are just delivered via telehealth or telephonically. We expect that to continue, but when we start to move to these hybrid models where we're delivering services in different ways, we're maybe doing 15 minutes of psychotherapy and texting and emailing and responding to portals, it really leads us to looking for those alternative payment models or value-based reimbursement models of care. Can we work with our payers to say, you're going to pay us a monthly case rate to take care of this person or other sorts of things, so we can be flexible about service delivery and not deliver services based on traditional billing codes. And amongst that, you also have to make sure you're complying with all the rules. So whatever the compliance requirements are, both from the payer and regulators, you need to address that with your model of care, particularly because it may be more challenging if you have staff working virtually and they're delivering services virtually or hybrid. How do you make sure everyone's following the rules? So our next step is really about, we can move on from this one, Sam. That's me just talking about payment transition, is training and supervising our service delivery staff. You know, when we have these new hybrid models of care, I was trained as a therapist in the 80s. Telehealth, I don't know that it existed in a way I knew back then. So, training our staff in our virtual models of care, making sure our electronic health record supports that, all those sorts of things need to be in place because staff have certainly learned how to use telehealth in the last year. But how do we support them in these hybrid models or making decisions about consumers that need face-to-face and virtual care? And so it's really developing those operational mechanisms to supervise our staff, because they may be virtual, that are delivering these new models of care. So the next step is making sure we have the right technology in place. I mentioned this before. There may be consumers that don't have laptops or phones or internet access. So obviously we can't deliver virtual or hybrid care to those folks. So both staff and consumers need the right tools. So these will be devices and internet access in order to do virtual and hybrid care. And I already mentioned there are great disparities in this sort of digital divide, where some folks have access to the technology and high-speed internet and some don't. And we have to figure out how to address that. So depending on who you serve and what jurisdictions, you may have some folks that you need to continue to serve face-to-face, not because they can't be served in virtual care, but because it's probably because they don't have internet, because you could give them a laptop or a phone or a device. And it's the same thing with the add-on technologies, is making sure we can figure out what we need and putting those things in place. The next step is really about looking at our overall operations and making sure it supports this new model of delivering clinical care. The list is really endless here. What are the new workflows? How does human resources work differently if we're hiring staff in other states who are doing virtual care for us? And, how does the billing work? How do we ensure quality and compliance, performance reporting, all those sorts of things? So you really need to revisit all those sort of administrative operations and workflows when you have significantly shifted to these innovative hybrid models of care. All right, so I've covered, I don't think I have any more steps, Sam. I think I'm moving on to the next piece here. I would ask you to remember when you put together your ideal model of hybrid care or face-to-face or virtual, whatever it is for the different cohorts, there will be individual consumers whose service model needs to be different. So think about this as the preferred model for serving cohorts of consumers, but you may run into an individual consumer where when you're doing their plan of care, their treatment plan, whatever you call it, you determine, you know what, for the first 3 months, this consumer really needs to be seen face-to-face for all things, and then we'll revisit it. So this is not cookie cutter. We're trying to think about it from a big picture. We're trying to move to digital whenever possible, but there's also a person-centered planning part of this where we're figuring out for an individual consumer what's best for him or her. All right, so those are my steps. Sam, let's move on to a slightly more boring piece. You can move to the next slide. The notion here, and again, I have a whole presentation about all of this, is when you're developing a new service line or modifying one, there are really good business models for how to do that. And certainly you can reach out to Sam and I if you want the more complete presentation of this. And if you're an elite member, you can, actually you're all elite members, you can find it on the website, but we're glad to send it to you. There are two broad phases in the process of launching new service line. The first is conducting the feasibility analysis, defining the services, looking at competition, doing the financial feasibility. And then the second is planning the launch, the new design, the preparation, the management, pilot testing, and other sorts of things. So I did want to drop this in because if you're really shifting services from just virtual to hybrid models, you really want to take a look at best business practices for doing that. But what I'd like to do now before we go to questions is really show you a case study of an organization I had the pleasure of working with last year. So this is really a case study about planning and launching virtual and hybrid services. So let me tell you a little bit about them. It's a very large, $200 million multi-state organization delivering a number of services, but primarily known for traditional outpatient mental health services in clinic settings, so traditional mental health services. Last March, they needed to quickly transition to virtual care like we all did, so all of a sudden they're doing thousands of telehealth visits a day instead of face-to-face visits. And that occurred within a week or two, astonishingly, because they already had the technology in place to make that happen. After the emergency part of the transition occurred, the first month or so, they really identified that their model of delivering care might be an opportunity to expand their services to more consumers, to more geographic areas, and increase revenues overall. And so part of what we worked with them on is really looking at research and product development so they could significantly expand their footprint. So again, going back to my previous slide, this is doing the research, who's out there, what are the opportunities, who are we competing with, will the math work, before they launched into just completely expanding their services. So that's the research and product development piece. So let me show you the steps if we move on to the next slide. So the first bullet point is they really updated their website, because if you're going to deliver virtual and hybrid care, people have to find you. If I have depression, serious mental illness of some sort, I'm going to go to Google and look for things. So they really updated their website and improved their SEO, search engine optimization, so that individuals could find them quickly. You want to be on the top of the Google page if someone's looking for mental health treatment, if you're this sort of provider. So the next thing that they did was they implemented a really true 24/7 call center. So you would go to the website and find it quickly, and then it would literally say, call 800 blah, 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 and there would actually be a human at the end of the phone 24/7, 365 days a year. So there's technology involved in making that happen, but the broad notion here is, in order to make hybrid work, they needed to have consumers identify them quickly and immediately have access to someone so they could talk about their needs and either get an appointment immediately or schedule an appointment. I do have a small bullet point here, because many of us, when we think of call centers, think of the old school thing where there's all these people in a big room wearing headsets. It doesn't work that way anymore. If I call Delta Airlines, which is my example in the bullet here, the person I'm talking to is probably working at home. He or she, is just connected to a phone system that routes calls in some priority level. So remember, when we think about doing a 24/7 call center or anything like it, it does not have to be a physical thing. It also can be virtual in the sense that we can use technology to route calls and quickly get people to our front end. So the next thing that they did was they really, part of the product development research was looking at the commercial insurances that were in the states of interest or the areas that they were looking at expanding services, as well as looking at payment rates. So they were already established in certain states, and they wanted to take a look at those contracts, but they wanted to see if they could expand those payer contracts to other states. They had some targeted states, but then they also looked at the reimbursement rates to decide, oh, you know what, I don't think we want to sell these services in these states, or, oh no, that makes sense. So again, this is part of that product development market research. The next thing they did, and again, they were looking to seriously expand their services, is figure out their outpatient virtual mental health services. They wanted to know who they were competing with. If you go to Google, there are lots of folks that I could get a mental health appointment for 35 bucks an hour, probably in the next 5 minutes. So they wanted to look at who are those national and local providers that they would be competing with to figure out how to differentiate themselves. Then the next thing they did was they really started to target the states they planned to work in, but they needed to hire a whole bunch of staff, and they were going to use independent contractors for this to be clinicians to deliver services. So it was interesting the way that we worked together to do this. So they picked a particular state. At Open Minds, we helped them develop a list of every licensed master's level clinician based on, things that were available at the state level or other sorts of research. And we actually sent out an electronic survey asking people if they were interested. And then interested parties were sent, contract packets, information, and other sorts of things. So if you think about this process, they decided they were going to seriously expand their outpatient mental health virtual services. They looked at the states that made sense to them. They looked at competitors, they looked at payers, and then they began moving on to, hiring the independent contractors that would actually deliver the services. So the next thing that the folks did was they had to deal with the fact that, okay, if we're delivering services, these contractors need to put the information into our electronic health record system. They need to know they have appointments. They need to do, do their progress notes. They need to do treatment plans. So this part was a bit more complicated. They had a software system that allowed them to develop what they called a mini EHR, meaning they didn't have to train these clinicians on everything. It only did the things they needed to see. And in their case, they also actually sent out equipment. So they sent out a company laptop. It had the EHR on it. They had a very brief training for the few things that these outpatient clinicians would need to do. And part of that decision about whether to hire a contractor was also based on how many hours he or she could work a week. Because certainly it doesn't make sense to spend the money to send someone a laptop if they're only going to work 1 hour every 2 weeks. So that was part of the complications. But fortunately, there were a lot of clinicians who were looking to do some additional work or to make this their full-time job. So the next thing that they did was they really had to take a look at all their performance and quality monitoring processes and figure out how to manage all of these, what would be hundreds of staff that were working remotely, many of which they never met in person. Next bullet point, please, Sam. And then additionally, and this is the part that made it hybrid for them, they contracted in jurisdictions where they didn't already have a physical presence. They contracted with nurses and psychiatrists to deliver the face-to-face services when needed. So for medication injections, more comprehensive psychiatric assessments. In the communities where they expected to have larger sets of consumers that they were delivering most of the services virtually to, they identified local partners in the places, again, they didn't actually have physical service delivery, that could deliver the face-to-face services. Okay, so that's my case study modified a little bit to show you what one particular provider did in planning their hybrid and some of the logistical steps. So let's move on from here. I really want to open it up, and Sam, we can close down the PowerPoint here to really, talk to our audience, or Sam, for you and I to chat a little bit about this in terms of what this means, how we move forward with it. The question I get the most often, Sam, is, how do we figure out which staff and which consumers this works well with? And what's interesting for me is we've probably already figured out which staff it works with well.
Absolutely.
Some folks work virtually well, like you and I do, and some folks don't do quite as well. But then when it comes to the consumers, folks were forced to deliver virtual care to consumers, even if it was less quality than they wanted. And I think it's really hard for folks to step back from that crisis mode and do what I talked about in the first step, which is to really, think about them outside of the pandemic, which is how could we best deliver care to folks?
Yeah, I think that was interesting. One of the things I was thinking about while you're giving your presentation was I remember about 1 to 2 months into the lockdown, people were saying, "Oh, things will never be the same again." And I thought, I don't know. I think people can recover, but now it's consumer behavior I think is forever changed, and that was one of the questions I had for you. I have a hypothetical provider in mind, and they're coming out of lockdown and they're thinking, great, this is over, I can go back to doing business the way I did before. What would you say to somebody like that?
I think my perception was like yours early on, but I think the world has changed. If I move to a different part of the world, grocery delivery. During the entire pandemic, my husband and I had all of groceries delivered. We had a Whole Foods, we had Instacart, we had all these, things that would bring us groceries. Now we're able to go to the grocery store again. But the reality is sometimes I'm like, but Whole Foods will deliver it for free and I don't have to drive there. And so I use that as an analogy because now consumers are like, I can get my therapy online. Why would I take the bus or drive there or spend the time when, I can do it here on my desktop? And so I think that, we were forced to do things virtually or remotely or all sorts of things. And now we're going, we're sort of used to that. But I do think there are some providers who really believe that things will go back to the old way. But I absolutely believe it's not true. And it also, Sam, it also makes us think about our office space. You live in Dallas. I don't know if you've ever even been to our offices in Gettysburg.
I have not. No.
We have a big giant office to our audience members where we can sit a whole lot of people. Hardly anyone's been there for the last 16 or 17 months. And so the question we ask ourselves, and certainly providers ask themselves, is do we need the big office space anymore? How many of our staff can work remotely? Our billing staff have been doing everything remotely for 16 months. Do we have to bring them in together? I have customers, a wonderful customer here in North Carolina that's reconfiguring their office space entirely. So it's more for collaborative meetings and not individual offices. So when we think about virtual, it's not just about the consumers we serve and what's best for them, which is the point of this presentation. It's also thinking about our staff and other sorts of things. Oh, I do have a question here, Sam, about where EHR technologies and other things fit in. And actually, I'm doing a presentation on this next week. So one of the things people have found during the pandemic is particularly about telehealth, is it's really nice to have an electronic health record where telehealth is built in, fully integrated. So when you schedule an appointment to see Sam, my therapist, the appointment schedule actually knows it's telehealth, and there's a click that actually opens it up, or other sorts of things, rather than have an entirely separate application. So I do know as we move to virtual and hybrid services, making sure our electronic health record fully integrates that rather than it be a separate thing is particularly helpful for staff and consumers.
That's interesting. It reminds me of the part of your presentation where you're talking about add-ins in hybrid, because it doesn't have to be all in, one way or the other. And then, once you have that developed and you have staff trained on it, you can use it as needed. It doesn't have to be all the time or none of the time.
Sure. Okay. So Joe, all those add-ins sound really cool, but who's going to pay for them? Again, this is where shifting to alternative payment models that move away from traditional fee-for-service make a real difference. I certainly know last year, even though it wasn't necessarily paid for, many of my provider customers, provided consumers with laptops or phones or, internet access in order to deliver services. They somehow came up with the money to do that. So, but I think the best model, particularly if we add on those add-ons that really, enhance hybrid services, it's really about shifting to a different way of payment. So that if I want to see Sam, my therapist, for 15 minutes, I can see him for 15 minutes, or I can text him, or even do a long email and he responds to me asynchronously. And that's all part of my treatment. But many of those things would not traditionally be able to be billed or paid for. But if Sam's being paid a case rate for me on a monthly basis, then it allows us to be much more flexible about how we deliver services.
And so you kind of touched on this, but I think the flexibility and everything that the technology has to offer, I have to imagine it's going to improve quality and also consumer satisfaction. Do you think that's going to continue to pressure traditional payment models, or do you think it's kind of already set in place with, who's on board and who's not?
It's a great question, Sam. So even pre-pandemic, we know that payers are moving to more value-based or outcome-based payment models. They're less interested in paying for us delivering services. They're interested in paying us to get outcomes. So if I have severe mental illness, maybe a major depressive disorder, and I'm periodically hospitalized, keeping me out of the hospital, keeping me living independently and employed and in a relationship, all those things are positive outcomes. And so we've seen that shift even before the pandemic, but the nice part about these virtual models of care and the hybrid stuff is it allows us to do that even more flexibly. And again, if we're talking about public payers like Medicaid or other sorts of things, it gets more complicated because of federal reporting requirements and other sorts of things. But the broad notion is if we can shift the way we're paid or payers pay us, it gives us more flexibility in delivering services, but we have to be able to demonstrate we're getting outcomes. Optum doesn't care whether you're texting or emailing or doing face-to-face or virtual, as long as you're keeping me out of the hospital. And again, just picking Optum as an example of the payer in the marketplace. But the broad notion is how we get it done should be up to us as clinical staff using all these new tools that we've learned and that are available on the market. But the only way we're going to convince folks to pay for it is if we can show that we're actually getting the results that are needed.
Perfect. Well, I think, are there any other questions? If not, we can move to the...
I don't see any more questions. So for those in the audience who are watching now or asynchronously, if you have questions or comments, you can always email them to us at Open Minds. It's easy to track us down. Sam and I will certainly be glad to respond to you. But listen, for our audience, thank you so much, Sam. It's always great to work with you. Hopefully you found this helpful. I believe, Sam, what's our event next week? Do we want to tell them about next week's event?
Yep, let me attempt at sharing my screen again. Let's see. I don't know, can you see anything?
I can see it.
Is it the PowerPoint?
Yep.
Okay, perfect. Okay, so couple announcements. Next week, we're going to have Making Strategy Work, Mission Growth and Sustainability. We have our Open Mind Senior Associate Ray Wolf with his friend Eric Lindy, President and CEO of Step by Step Inc. This one will be sponsored by Qualifax Incredible. So it's going to be open to anybody, not just elite members. So feel free to share that with any of your friends or colleagues, regardless of their membership status with Open Minds. And then secondly, we have our Management Best Practice Institute next month, August 23rd through 27th, and sunny.
It's actually this month, Sam, unfortunately, so I should do my presentation soon. It's just 3 weeks away.
We got to get on that, Joe. But yeah, I think this is going to be really fun. We do have contingency plans in place in case Delta throws us a curveball. You can register at management.openminds.com. Joe, I don't know if you have a couple words about the MBPI.
Yeah, this is, we do 5 major institutes a year, and certainly our elite members know that they come to many of this one is our Management Best Practices Institute. We have a great faculty here. There's lots of workshops as well as seminars and other sorts of things. So you can go to the website to see it. Sam is highlighting some of the key speakers here. So this is actually our first face-to-face event, assuming that there's no snags in making that occur. So definitely, if you can make it to California, come to that. Our next conference after this is, institute after this is actually my favorite one. Sam doesn't have a slide for it, but it's our executive leadership retreat in September in Gettysburg, where we use the Battle of Gettysburg as a way to teach people about leadership and management and other sorts of things. But enough of the commercials, Sam. Let's let our audience go. Again, thanks to folks for attending. You'll get the slides and the video if you want to watch this over and over and share it with your family. That would be great. And then, yeah, certainly we look forward to seeing you at one of our next events. So, Sam, thank you so much for your help, and to our audience, it's great to have you.
Thank you, Joe. Thanks, everyone. We'll see you next week.
Bye-bye.